Rise. Let's have a brief look into the cardiac anesthesia in this session. I request Dr. Prabhakar V. Sir to occupy the chair on the dais. Dr. V. Prabhakar, MD/DM in Cardiac Anesthesia, is the Professor and HOD of Department of Cardiac Anesthesia, Jayadeva Institute of Cardiology, Bangalore. We welcome you, sir. I request our respected HOD, sir, Dr. V.V. Srinivas, to come up on the stage and chair the session. Professor and HOD of the Department of Anesthesiology of MMCRI, Mysore. He is the postgraduate guide since 13 years. He has 35 national and international publications, and he is the present ISI Mysore branch treasurer since 2012. We welcome you, sir. Now I call upon Dr. Aruna Parameshwari ma'am to deliver a CME talk on perioperative MI during non-cardiac surgeries. Welcome, ma'am. I request the chairpersons to introduce the speaker to the audience, please.
This one, can I see my slides in this? A very good morning, everyone. At the outset, I would like to thank the organizers for this opportunity to be here today. We are going to be looking at perioperative myocardial infarction in non-cardiac surgeries over the next 20 minutes. So the outline of my lecture will be, what is the definition of myocardial infarction and what are the different types? What is the pathophysiology? What are the perioperative triggers? How do we prevent? How do we diagnose? And how do we treat? Now, myocardial infarction is a very common and feared complication of non-cardiac surgery. The incidence is highly variable from 1 to 17% depending upon the particular study published, and the mortality range, inpatient mortality, is anywhere between 5 to 25%. The incidence actually peaks in the first 3 postoperative days. So what is the definition of myocardial infarction? Now, several definitions have evolved over the years. The current definition is what is called the 4th universal definition of myocardial infarction, which was definition came up in 2018. So according to this, it is a clinical or a pathological event. The two phrases to remember in this is in the setting of myocardial ischemia, in which there is evidence of myocardial injury and cell death. So what is the setting of myocardial ischemia? We either need symptoms of ischemia or ischemic ECG changes or new wall motion abnormalities on echo or an imaging. You need a fixed defect on radionuclide scanning, or you have to demonstrate the thrombus, either autopsy because it was a fatal MI or by coronary angiography. So one of this has to be present to define it as a myocardial infarction. And the second is that there is myocardial injury as evidenced by rise in cardiac troponin levels. How much rise? It should be one value above the 99th percentile upper reference limit. What is this reference limit? We will look at it through the course of this lecture. Now, another terminology has been introduced called myocardial injury after non-cardiac surgery because of the prognostic value of the cardiac markers, biomarkers. So this includes both myocardial infarction as well as ischemic myocardial injury, which does not fit into the universal definition of myocardial infarction. So what do we mean by myocardial injury after non-cardiac surgery? There is cell injury, myocardial cell injury as evidenced by elevated cardiac troponin, assumed to be a presumed ischemic mechanism, which happens anytime in the 30 days following non-cardiac surgery. So we have to exclude conditions like pulmonary embolism, sepsis, cardioversion, and rapid atrial fibrillation because these will not be falling under myocardial injury after non-cardiac surgery, though they do cause myocardial injury. It's only when it is supposed to be of an ischemic etiology, it is called as myocardial injury after non-cardiac surgery. So whole thing is actually a spectrum from no injury to myocardial injury to an acute MI. So acute myocardial infarction, to define this, there is myocardial injury as evidenced by rise in cardiac troponin levels. This rise is acute and this rise is in an ischemic setting. So how do we classify myocardial infarction? There are 5 different types. Type 1 is because of an atherosclerotic plaque rupture. Type 2 is MI because of an oxygen supply demand imbalance. Type 3 is when the patient has had a cardiac death and we did not have time to send biomarkers to diagnose the infarct. Type 4 is a myocardial infarction occurring in the setting of a percutaneous coronary intervention, and type 5 is myocardial infarction occurring in the setting of a CABG. I'm only going to stick myself to type 1 and type 2 for non-cardiac surgery. So what is the pathophysiology? So type 1, when you say, we said it's an atherosclerotic plaque rupture, which means the patient already has atherosclerotic plaques. Now this plaque rupture results in intraluminal thrombus and occlusion. Now this occlusion can be complete, in which case we have an ST elevation myocardial infarction, or it can be an incomplete occlusion, in which case we have a non-NSTEMI, which means ST elevation is not there. We most likely have ST depression and T-wave inversion. So what is the type 2 MI then? It could be in a setting of a stable flow limiting lesion in the presence of atherosclerosis. Several things happen perioperatively which increase the oxygen demand or decrease the oxygen supply. This term also includes conditions like coronary vasospasm, coronary dissections, etc. So all this will fall under the blanket of type 2 myocardial infarction, where the basic problem is a supply-demand mismatch in myocardial oxygen delivery. So we know what are the factors which decrease the oxygen supply. Tachycardia is one of the causes because myocardial supply happens only during diastolic filling. Whenever there is going to be a tachycardia, there is a decrease in the diastolic filling time. Hypotension will decrease because we know coronary perfusion pressure depends upon the aortic diastolic pressure. Hypoxemia and anemia will affect because the content of oxygen in the blood that reaches the heart is going to be less. Similarly, conditions like hypocapnia can cause coronary vasoconstriction and decrease the oxygen supply. What are the conditions which increase the demand? Again, tachycardia will increase the demand as well. Hypertension or any other increase in the LV wall stress is going to increase it. So if you look at the categories of perioperative, we spoke about STEMI and NSTEMI. So if the ECG shows ST elevation, it's called a STEMI, and in most instances, it's because of a complete occlusion of an epicardial coronary artery. All the others fall under, if there is no ST elevation and it's a myocardial infarction, it's called an NSTEMI. This could either be because of a partial or incomplete occlusion, or it can be because of a supply-demand mismatch. Now, is perioperative myocardial infarction type 1 or type 2 more commonly? So most of the information regarding this has come about whenever a patient had a perioperative MI, coronary angiography was done to see if there is an occlusive thrombus in a vessel, whether the culprit vessel was found or not. Based on that, based on the type of ECG changes which happen in the perioperative MI, do we have ST elevation more common or ST depression? It's been found that ST depression occurs more commonly rather than ST elevation MI. And also based on fatal MI, the post-mortem studies, they found out whether there is a coronary thrombus occluding it or not. Based on this, in several published studies, it has been shown that 70% of the perioperative myocardial infarction belong to type 2. Some 25 to 30% could still be type 1. So why does this happen in non-cardiac surgery? There are a number of perioperative triggers. We know surgery is a pro-inflammatory, pro-thrombotic state. So there is always inflammation with platelet aggregation, decreased fibrinolysis, increased procoagulants, decreased anticoagulants. So the stage is set for an occlusive thrombus to develop. In addition, there is a stress response and sympathetic stimulation of pain and tissue trauma and a lot of hemodynamic changes. All these can cause type 1 as well as type 2 because, for example, you have hypertension. It can increase the shear stress on an atherosclerotic plaque, causing it to rupture, and then the prothrombotic state causes an occlusive thrombus formation. Hypertension can also affect the oxygen supply-demand mismatch. So the triggering factors can cause either a type 1 or a type 2 MI. Similarly, hypothermia, hypoxia, hypocapnia, major intraoperative bleeding in non-cardiac surgery can cause anemia. But most of this happens when the patient has a pre-existing coronary artery disease and some stable coronary artery disease that you develop. It doesn't happen in someone who does not have any coronary artery disease at all. It is very unusual. So how do we prevent? So as anesthesiologists, we want to prevent. So the first step is to identify which are these patients who are likely at risk of developing a perioperative MI and to give a good perioperative care. So how do we identify these patients? It's by patient-related factors. There are published factors which you have to look at. If you look at the demographics, it's more common higher the age, especially more than 65 years, and in the male sex. If you look at the functional capacity is low. If the patient has other atherosclerosis-associated comorbidities, hypertension, diabetes, coronary artery disease, cerebrovascular disease, peripheral vascular disease. The patient has other cardiovascular conditions like heart failure or atrial fibrillation and chronic kidney disease, diabetes, obstructive sleep apnea. So these patients are all, you already know that they are at high risk of cardiac events. We also have composite risk indices. Several of them are there. The commonly used one is the revised cardiac risk index and also obesity. That's why OSA is also taken into account. If you look at the RCRI, it consists of all these variables, each of which is given a score of 1. Higher the score, especially a score of more than 3, the risk of perioperative MACE is almost 15%. So it includes diabetes, CKD, and also ischemic heart disease, cerebrovascular disease, and congestive heart failure. And very important, in addition, is the type of surgery. In addition, we also get a clue on which patient is at risk by looking at preoperative investigations, especially the ECG, the troponins, the BNP. Similarly, impaired post-exercise heart rate recovery, elevated blood glucose, a neutrophil lymphocyte ratio more than 4, which indicates an inflammatory condition. All this says that this patient could be at a higher risk. The other thing is the surgery type. Emergency surgery, the patients are more at risk. Regarding elective surgeries, there are some surgeries which are classified as high-risk surgeries. Adrenal resection, major vascular procedures, major gastrointestinal procedures, thoracotomy, all these come under high-risk surgery. So if you have a high-risk patient coming for a high-risk surgery, then they are very likely to develop, and we have to take extra precaution to make sure the anesthesia care is appropriate. So we can also identify the high-risk patient using investigations like ECG, cardiac troponins, NT-proBNP, and if the functional capacity cannot be assessed, then it is better to do a stress test to find out if they are prone for myocardial ischemia. Now, troponin screening is recommended for most of these patients. If you look at the current European guidelines, what it recommends is the surgical risk is also high, the patient risk is also high. You have someone who is more than 65 years or more than 45 years with many of the cardiovascular risk factors. It is better to do an ECG and a troponin screening pre-op itself and repeat the troponin screening post-operatively on day 1, 2, and 3, because many times the patients are asymptomatic, and that is the reason the MI is missed in the post-operative period before it becomes fatal. What about prevention? A good anesthesia care is mandatory. All these patients will be on beta blockers, aspirin, statins, nitroglycerin, AC inhibitors. All these drugs are continued, and if there's LV dysfunction, AC inhibitors are also continued perioperatively, though we have a tendency to stop them, worried about intraoperative hypotension. But if there's LV dysfunction, it is better to continue the AC inhibitors as well. Good perioperative care is appropriate anesthesia management. It starts off with the adequate basal monitoring. All of these patients should have minimum 5 to 6 electrodes applied on the patient and minimum 3 leads to be monitored. You also have to monitor the invasive blood pressure, because it has been shown that even a small duration of massive hypotension or a long period of moderate hypotension is associated with an increased risk of perioperative MI. So if you look at this publication looking at intraoperative hypotension and myocardial infarction, you find that if the blood pressure falls 20 to 40 millimeter of mercury itself from the baseline, the risk increases. And if it's going to fall to more than 50 millimeter of mercury, the risk is much higher. So it is very important to maintain blood pressure. And ECG, most of the current monitors actually allow you to capture the 12-lead ECG itself. So ECG and blood pressure monitoring and monitoring temperature, because we want to avoid hypothermia, SpO2, EtCO2, all this becomes very, very important. And you can escalate the monitoring depending upon the type of surgery we are doing. You might insert a central venous pressure, non-invasive cardiac output, invasive cardiac output, or an echocardiography. Induction, common thing, this is a non-cardiac surgery. Normally we induce with thiopentone or propofol. Probably it is safer to use etomidate in these patients or only use titrated propofol. Similarly, intubation, we have to take steps to avoid the sympathetic stimulation. Usually in these patients, the hemodynamic response is much lesser with a video laryngoscope compared to a conventional direct laryngoscopy. And there are a lot of drugs to attenuate it, intravenous anesthetics, lignocaine, beta blockers, dexmedetomidine. We can choose the combination which works. Ventilation, specifically, it is important to avoid hypoxia, hypocapnia, and high ventilating pressures itself, which can cause hypotension, and have an optimal PEEP. Blood loss, it's also been shown that when there is more than 4 units of blood transfusion which is required intraoperatively in these patients, they are very likely to develop a perioperative myocardial injury. So we have to be very careful in assessing the blood loss and aggressively replace to prevent the anemia. Analgesia is very important. So wherever possible, use regional anesthesia. And remember that post-operatively, these triggers of pain and inflammation could be there. So wherever possible, use continuous catheters or use adjuvants to prolong your regional analgesia. Whenever you're using an epidural anesthetic, be careful about the dosage to avoid the hypotension of sympathectomy. Hypothermia is another killer as far as myocardial ischemia is concerned, because it can result in increased sympathetic stimulation, and shivering is going to increase the myocardial consumption terribly. So we have to take every effort to control it by using hemotherms, fluid warmers, forced air warmers. That's all about prevention. Moving on to diagnosis. We have clinical features, ECG, biomarkers, and echocardiography. Looking at the clinical features, these are the normal, in a non-operative setup, these are the symptoms which the patient will be presenting with. The problem with the operative setup is chest pain is absent or atypical, or we might not have it in more than 65% of patients because many of them are on opioid analgesics or under the effect of sedative drugs. We might have to rely on diagnosis based on the hemodynamic instability or the respiratory changes which we find. The ECG diagnosis of STEMI, it's all very definite. You just look at the ST elevation has to be more than 2 millimeters in men more than 40 years of age. If they are less than 40 years, it's 0.5 millimeter, 2.5 millimeter. If it is going to be a woman, it's going to be 1 millimeter. This is in V2 to V3 leads, or it should be more than 1 millimeter in all other leads. The thing is, it has to be in at least 2 anatomically contiguous leads. So what do we mean by anatomically contiguous leads? These are leads which lie next to each other and represent a particular area of the myocardium. So 1 an AVL, 2, 3 AVF. So each area is depicted according to a particular artery which it supplies. So we have to be aware of this. Also, whenever there is an ST elevation MI, there can be ST depression in the reciprocal leads. So we need to know which leads are reciprocal to which, so that we'll know that if there is an ST depression there, we also have to look for ST elevation in the other leads. And new onset Q waves. So this is all for EC diagnosis of STEMI. What about non-STEMI? There is ST depression more than 1 millimeter in 2 contiguous leads, or a T wave inversion more than 1 millimeter in 2 contiguous leads. Regarding the morphology of ST depression, what is important is the depression has to be horizontal or downsloping. The upsloping ST depression is not significant of myocardial ischemia. Moving on to biomarkers, what we commonly use is the cardiac troponin. So what are these cardiac troponins? They are proteins that are integral components of the cardiac contractile apparatus, which are going to get released into the circulation whenever there is going to be myocardial injury. Troponin I is the inhibitory fraction, and troponin T is the tropomyosin binding fraction. That's all. It's called T and it's called I, and troponin C is for calcium binding. So I and T are having very good myocardial tissue specificity, and there are immunoassays to capture the levels of these substances in the blood. So what is the pathological troponin level? So to say it's myocardial injury, it should be more than the upper reference limit of the 99th percentile. What is this upper reference limit? If you say it is 10 to 20 nanogram per liter. So 20 nanogram per liter is the upper reference limit. So whenever the troponin is more than 20 nanogram per liter, it means there is myocardial injury. If there is a rise or a fall from the previous value, you know this injury is acute and it is not chronic. 20% rise above the previous level also indicates is acute, and a difference of more than 5 nanogram per liter. You have one value above 20 and the next value comes as 30, then it is definitely abnormal and you can say the patient has had a myocardial infarction. Regarding the timelines of the troponin rise, we should be aware that STEMI produces the maximum height compared to non-STEMI, and the earliest rise is the initial 0 to 3 hours. After that it tapers and there's a second peak around 3 to 5 days. The higher the troponin, the greater the myocardial damage and higher the mortality. But it's also important to remember that it has to be an ischemic setting because there are a lot of differential diagnoses, both cardiac and non-cardiac conditions where the troponin levels could be high. So this is the diagnostic spectrum. Start with clinical signs, do an ECG, do a troponin, see if there is a rising value, rule in myocardial infarction or rule out myocardial infarction. Echocardiography is a non-invasive test. The problem is, although it has a high sensitivity, the specificity for myocardial infarction is less. You can make out regional wall motion abnormalities, but these are present even in a previous myocardial infarction or if there's a cardiomyopathy or a myocarditis. But it's very helpful in detecting complications of MI. For example, there is a papillary muscle rupture, an acute mitral regurgitation, or a ventricular free wall rupture. All this can be made out by echocardiography. So there is a standard 16 or 17 segment model to find out which area is infarcted. Moving on to the final phase, how do we treat the myocardial infarction? We have standard guidelines on treating STEMI and non-STEMI. The European Society guidelines, our 2020 guidelines are there for managing non-STEMI. So the most important is to communicate with the surgical team and the cardiology team, ensure adequate oxygenation and ventilation, administer aspirin 325 milligrams immediately, administer anticoagulants. The problem with anticoagulants is you have to consider the bleeding risk of the particular surgery because this patient has had a surgery. If the last 0 to 24 hours, then there is a risk of bleeding depending upon the particular surgery. Then of course nitroglycerin, statins and beta blockers are all added. Hemodynamic instability, we will have to take care using fluids, blood, vasopressors, inotropes, or an IABP if need be. Correct all the metabolic anomalies, acidosis, hypothermia, electrolyte and metabolic disturbances, escalate our monitoring, and also order all the labs, ABG, electrolytes, and a basic metabolic panel, and treat complications. The two common complications are cardiogenic shock and malignant arrhythmias, or there will be a cardiac arrest. So we should be able to manage all this. In non-STEMI, immediate invasive strategy is recommended if these are all high-risk patients. Within 2 hours, the patient will need a coronary angiography. If the patient is not so high risk, the coronary angiography can be delayed for 24 hours. What about STEMI? The current guideline STEMI is you have to take the patient for a primary coronary intervention. Time to balloon is less than 60 minutes if you have a PCI in your setup itself. Antiplatelets, loading dose, it's a 1A recommendation to use prasugrel, ticagrelor. Aspirin is a 1B recommendation. Anticoagulants, unfractionated heparin is recommended, otherwise enoxaparin can be given, and statins and beta blockers. This is all the recommendation for STEMI in a non-perioperative setup. So fibrinolytic therapy is not indicated for treating myocardial infarction in the perioperative setting. But the other thing is we do not have specific guidelines on what to do in the perioperative setup. But we have to balance the ischemic risk versus the bleeding risk. So to conclude, we saw the definition of what is myocardial infarction, what is the pathophysiology, what are the perioperative triggers, how do we diagnose, how do you manage. Thank you very much for your patient hearing.